الناس هاي ممكن تعمل admit all. Right, okay, we are now live on Facebook. um, بسم الله الرحمن الرحيم. مرحبا كل الناس المعانا في الزوم واللي بتابعونا عبر الفيسبوك. أنا مصطفى مختار. I'm pleased to be with you. This session, I already spoke about this session before, and we had good interaction with from people, and I think it is one of the important things for family physicians to become familiar with, which is how do we think, how do we make decisions, um, how do we diagnose, what is the process that is happening in our mind, and that is what is known as the clinical reasoning. Becoming aware of the process of clinical reasoning is very important in telling us about the biases, about the flaws in our decisions that happens, and we'll also see why is it very relevant to family physicians more than any other specialists. Right, this is where I work. I'm a GP trainer, training program director in the UK. I also work as I said, as a training program director with Health Education England. Now I'm gonna start with story قصة خليل، وعاوز أي واحد من الناس الموجودين unmute yourself and assume إنه جاك خليل. assume إنه أنا خليل 52-year-old gentleman complaining of abdominal pain. إنه أنا جيتك قلت لك والله يا أخي عندي ألم في البطن يا دكتور. anybody just unmute yourself and what question do you want to ask me?
السلام عليكم.
وعليكم السلام آلاء.
طيب I will ask Mr. Khalil about what kind of pain, where is the site of pain.
والله الألم كده بس يعني والله بس يعني وجع كده، وجع حاد في البطن يعني.
طيب لو قلت لك توصف لي حدته أو شدته، وقلنا مثلا من 1 ل4 الألم بسيط، من 4 ل7 متوسط، من 7 ل10 حاد، أنت بتدي روحك كم؟
6.
طيب تمام. فيها منطقة في البطن
والله البطن كلها
بتوجعك؟ في حاجة معينة بتزيد لك؟
لا
في حاجة بتروحه؟ طيب
لا
طيب بدل من 200
له زي 3 أسابيع.
3 أسابيع. طب هل معاه أي صمام؟
لا
معاه استفراغ؟
لا يا دكتورة ما في.
معاه أي تغيير في الفسحة؟
لا ما في.
ما في حرقان؟
مرة بيجي حرقان لكن ما كتير.
طيب طيب معلش يا سيد خليل السؤال بس، هل أنت بتشرب سجاير؟
يعني مرة يعني، لكن ما كتير، بسيط يعني.
طب هل بتتناول أي مشروب كحولي؟
لا يا
مشروب
دكتور.
روحاني؟
لا.
طيب يا سيد خليل، أنت طبيعة عملك شنو؟
أنا سواق، بس سواق بتاع أمجاد.
سواق بتاع أمجاد. طب في الفترة اللي كان فيها الألم بتاع البطن ده له 3 أسابيع زي ما أنت ذكرتها، حسيت إنه وزنك نزل؟
ما متأكد والله، ما شفته. تمام.
وزنك
alright,
ما
so
زاد عليك؟
تمام يا آلاء. thank you very much, and that's a very good history. Now, okay, so you had about 4 or 5 minutes in the history. So what is the diagnosis? Okay, and I'm not going to put you on the spot for that, but I just want everybody to try to think. So did you actually reach any diagnosis? Although this is how a good history by the way we've been taught medicine is, if you think of it, it probably takes you so far. It probably, yes, it is the right way, that is the way that we've been taught in the medical school, in our housemanship, how to take history. But you might feel it can easily take you to nowhere. And if you sit with an experienced family physician taking a history in a very short time, you will probably notice that the way they take the history is completely different from this. It's not that structure, it's not that tick box, it's not that list of items that you have to do. Now, so what we've just heard now, that's fine, Ala. I think that is very good. This is the medical student or house officer way of taking a history. And when we talk about how family physicians are different, it's the way they utilize how our brain processes information to reach a diagnosis. And I will explain that in a minute. Now, how does our brain diagnose the conditions? Now, keep in your mind what the history that Ala just took, and I want you to think of this. Spot the diagnosis. Now, this is not that patient. This is just a completely different thing that I want you to tell me what is the diagnosis.
Herpes
Yes,
zoster.
yes, yeah, the herpes zoster. Yes, so I think most of us, shingles came to your mind. I think that is the first thing that comes to your mind. As soon as you see this picture, shingles jumps into your mind. Now, how does that happen? We'll talk about this. Now, if I tell you that this patient has this rash on the other side of his torso as well, so the same this is on the left side, on the right side he's got the same rash. If I tell you that or if I tell you that he has had this rash for 5 years and it hasn't changed, now you find yourself trying to consume a little bit of energy and trying to question shingles, to try to think differently, to try to widen the diagnosis, as if your brain stopped responding to the first episode of shingles, and you are now starting to go into analyzing, trying to analyze things, try to think widely. And I will tell you the difference between these two. Now, by the way, you are right, this is shingles, but what our brain likes to do is to jump to the diagnosis. Why? Because that is what we call system 1 of thinking. It consumes less energy, and the brain is lazy, try to conserve the energy, so it just gives you the diagnosis. But questioning your first impression is very vital. Trying to think widely, try to deduct the possibilities is what we are going to talk about today, inshallah. يبقى حنتكلم عن understanding what is meant by clinical reasoning, and trying to identify the importance of studying clinical reasoning. لأنه ممكن زول يقول لنا أخواننا الكلام ده مع تنظير ساعة يعني, so what is it that I'm going to achieve from this, and also try to recognize the practical application of this in practice. طيب, we'll give you a chance to read this definition. Clinical reasoning is the process used by clinicians to collect and evaluate data and to make judgments about the diagnosis and management of patient problems. يعني لو جاك زول بوس قال لك يا أخي البوس ده بس بيشوف الحاجة كده وطوالي بيديك التشخيص, بيقول لك shingles, بيعاين للزول ماشي كده بس بيقول لك Guillain-Barré syndrome. That is not the clinical reasoning that you would like, and unfortunately this has been exaggerated. إحنا يعني during the housemanship في السودان كنا يقول لك يا زول الأخصائي ده خطير جدا, بيشوف الزول بيجي خاش كده, بيجي خاش الغرفة كده بوريك التشخيص شنو. that doesn't put in consideration the nature of the human brain. They are just thinking with type system 1 of thinking. System 1 thinking is okay, but if not challenged, if it's allowed to make all the diagnoses, that would be that it can easily fall in traps. So collecting data, evaluating them, and making judgment on diagnosis and management based on this. why are we bothered بالكلام ده؟ أول حاجة بتخلينا to become aware of the flaws in decision making، وحنتكلم بعد شوية عن البايسز اللي ممكن تقع فيها بسهولة if you are not aware of the process of clinical reasoning. الحاجة الثانية it helps recognizing the biases in others, and actually this is actually easier than the first one. You can easily recognize biases in other people when you study clinical reasoning, when you if you are in a lecture like this, than recognizing them in your own self. And it's also a tool for safer diagnostic strategies. A more pragmatic approach, and I will explain later what I mean by how do we make a pragmatic approach. Family physicians are more pragmatic than specialists because they work on marginalizing errors. They try to be practical when there is no diagnosis possible or no diagnosis is clear. يبقى the idea of clinical reasoning, we are not talking about black and white. It's not about right or wrong. It's the process that you want to reach a reasonable, practical way of helping this patient. So it's about probabilities. Is it most likely or is it unlikely? في two models of clinical reason that there are more than two, maybe 4 or 5, but these are the two major models of clinical reasoning. هتكلم عنهم الاثنين, the dual system model and the hypothesis deductive model. طيب قصدنا شنو بالdual system model؟ dual يعني two. dual system model, this is mainly by psychologists. بيقولوا إنه the way we think is through two systems, system 1 and system 2. دي كلها أسماء لسيستم 1 وسيستم 2. over the last 60 years every time بيجي psychologist بديهم أسماء مختلفة لكن is the same idea. يعني ده كيث ستانوفيتش هو أول واحد هو سماها type 1 and type 2. system 1 and system 2 is by Daniel Kahneman, a Nobel Prize winner. لأنه هو اشتغل فيها شغل كتير جدا وعمل فيها دراسات كتيرة جدا. فالفكرة إنه we think in system 1, or let us call it type 1, or the fast thinking, or the first impression, or the autonomous thinking, or the gut feeling. All of these are the same thing. It's the first impression that comes to you. لو قلت لك 4 و4 كم بتجيك 8 في ذهنك بتجيك 8. You don't, this is system 1 for an adult. Maybe for a very young child مثلا 4-5-year-old قد يحتاج يستخدم system 2 يقعد 4 بالأصابع 5-6 عشان يعملها. That consumes more energy. The same computation for someone who is experienced, it might become like this. Now in very experienced doctors, some decisions which are normally required to be done through system 2 can be done through system 1. And yes, that might save a lot of time, but it makes them vulnerable to errors. So يبقى ده system 1. system 2 is when you analyze. system 2 لما أقول لك 23 زائد 154, you need to think a little bit. You need to consume some energy. You need to put the possibilities there. فده system 2. Although you can tell the answer to both these questions, 2 و2 كم 25 و3 و142 كم, you can tell the answer to both questions. You use different way of thinking in both of them, and we need to be aware of both of them when we make diagnoses and decisions. طيب, question: which line is longer? أطول الخط الفوق ولا التحت؟
The same.
They are the same. طيب لكن حتى بعد ما أقول لك they are the same, still you think your brain is telling you no, the top one is longer. Even though you know they are the same, you might need to take a screenshot وبعدك تعمل لهم measurement with a ruler to convince yourself. When you measure them with a ruler and you know that they are the same, that is system 2. When you look at them to say which one is longer, system 1 is telling you the top one is longer. The same them with these two tables, famous tables by Shepard. He drew them in 1990s. You know, which one of these tables is bigger than the other? Will take more cups than the other. These are actually the same table, but it has been put with a different orientation. Now, no matter how hard you try to convince yourself that it is the same, they just look different. This one looks longer, and this one looks rectangular, and this one looks more of like a square shape. But they are the same table. If you take a screenshot and you measure from here to here, it will be the same distance as this one, and if you measure this, it will be the same as this one. And I personally I only convince myself بعد ما عملت سكرين شوت وبعد ذاك قستهم and they are the same. But actually there is some illusion that comes to you from the legs of the table that gives you that impression. Right, now have a read through this just to tell you an example of system 1 thinking. A man and his son were in a car accident. The man died in the way to hospital, but the son was rushed to surgery. The surgeon looked at the boy and said, "I can't operate. That is my son." So how is that possible? I don't know if there is anything on the chat.
Maybe he just looks like his son, or maybe he means his grandson.
Okay. Someone says stepdad, someone says confused, the surgeon is confused. Yeah, absolutely, thanks we am. Yes, thanks we am. The mother is the surgeon. The surgeon is the mother, but your brain has got a picture of a surgeon. We all know that that a surgeon could be a man or a woman. We know that, but we don't think of that. So I'm going to explain to you later why does your brain not think of a woman when we say surgeon. It's a phenomenon called representation, which I'll explain shortly. So system 1 has got a number of features, and I will pick on 3 of them: availability, representation, and anchoring. The one in the middle is the phenomenon that happened to most of us when we thought of the surgeon. It's representation. What does that mean? There is a picture in our brain for different categories. That picture is built on from our knowledge, our experience, our childhood, our culture, and our values and our norms. Now, system 1 gives you decisive decisions, doesn't give you probabilities, doesn't give you options. It just gives you an overconfident decision. When you say, okay, so the surgeon, that is a man, so it gives you a picture, so that is the representation. When you say when you say a surgeon, you get a representation of a man. You even sometimes think of how that man looks like. Right. Availability is the idea that if you experience something recently and it's very easy in your memory, easily retrievable from your memory, your brain will analyze that as how frequent this probability is happening. يعني شنو؟ أنا أكتر مثال بقوله إنه افترض إنك أنت قاعد تقرأ مثلا، قول يوم السبت مثلا دخلت لك ويب سايتس، مسكت لك كتب ولا أي حاجة وقعدت تقرأ مثلا عن dermatomyositis أو كود إيكواين سيندروم مثلا، وعرفت عن أي حاجة، عرفت عن كود إيكواين سيندروم everything in and out you did and you loved it. تاني يوم الأحد في العيادة بتاعتك you might diagnose 3 code equine syndrome. We all know it is a very rare occurrence that you can't really diagnose 3 code equine in one day if you are working in family medicine. Or if you for example قريت عن dermatomyositis تاني يوم تشخص 3 dermatomyositis, the possibility of someone having both osteoarthritis and dermatitis or eczema at the same time is more likely than someone having dermatomyositis because it's very rare. So having 2 or 3 dermatomyositis in one clinic can make you think, oh, am I biased here? So فبتلاحظ الحاجة اللي انت قريتها قريب ولا شفتها قريب ولا حضرت عنها محاضرة قريب، بتحس كأنه في عيانين كتار جوك بيها. actually هل في عيانين كتار جوك بيها ولا انت الثريشولد بتاعك to diagnose this is very low because of the availability phenomenon. يعني ال availability بتاعت الحاجة في الميموري, because you can easily bring it from the memory. System 1 will tell you that this is very common. And I always say, what is the most important information about rare conditions? The most important information is the fact that they are rare. But when you read the textbook, your brain would ignore. I mean, the first thing لما تقرأ عن dermatomyositis it says it's a rare condition, but your brain would ignore that and will look at how typical dermatomyositis presents. And that is the problem. So and I mean لو بتتذكروا يعني in medical school we used to be told try to think of uncommon presentation of common conditions rather than common presentations of uncommon conditions. Now, what is anchoring? Anchoring is a process of your brain being attached somewhere, and then when you make decisions afterward, you try to mobilize your thinking from that place, and this mobilization will not go very far. طيب أو أشرحها بطريقة ثانية. If you are doing a blood pressure monitoring clinic and a patient came to you, normally her blood pressure is 190 over 120, something like that, very high. اليوم داك جاتك والبلود pressure كان 160 over 100, and then you tell her your blood pressure is high, بتقول لك ده كويس شديد انت ما عارف بيكون كيف. Or a diabetic patient when you check their fasting glucose and it's 140 for example milligram per deciliter, يقوم يقول لك أنا الصيام حقي عادة بيكون 190, ده كويس شديد. Now because of the anchoring, we go anchored to very high number, then we do accept a fasting glucose of 140, although it is still not normal, or a blood pressure of 160 over 100. That's still not normal, but we don't think of it in that way because we were anchored to that number. Now, anchoring can happen between 2 patients. So you saw the first patient and the first patient has got a very high blood pressure. The second one has got a high blood pressure but not as high as the first one. لو ما كان شفت الأول كان احتمال إذا عاملت مع الثاني as high blood pressure. But because you saw the first one and you are anchored to that high, الثاني ده بيشوف لك ده كويس يا أخي. Now it might be, I might be exaggerating it because in blood pressure and diabetes we have numbers. But anchoring can happen in a very subtle way. يعني بطرق ألطف شوية أنت ما بتقدر تلاحظها. ما في when there are no numbers. For example, how demanding a patient is. So if the first patient is very demanding from you, and the second one didn't demand a lot, or they demanded but less than the first one, then you wouldn't feel them as demanding as they were, and so on. So this is the anchoring that we need to be aware of. عشان كده if you saw a patient, what I advise is if you saw a patient وبعد ذاك كان either a difficult patient, very complex or challenging patient, or something made you emotional, and you think the memory of that patient is and their presentation is stuck in your brain, my advice is have a break. اطلع امشي اشرب لك شاي اعمل اي حاجة ثانية. Try to delete that memory, try to see the next patient fresh to avoid the bias of anchoring. طيب the hypothesis deductive method is the second way. لو الناس معانا what is the first theory of clinical reasoning? Yes, the dual system way. Thanks, Asma. The dual system way is the first one. The second one is the hypothesis deductive model. الفكرة شنو تحت الhypothesis deductive model؟ إنه وأنا حرجحكم لخليل اللي هو الجبهة abdominal pain وبعد ذاك شلنا منه history في البداية. The way family physicians take history is slightly different from the way the medical students take history. It's not about listing, asking about abdominal pain, size, frequency, consistency, aggravating, relieving factor, radiation. This is a medical student way to remember this, which is fine. But as a family physician, you ask questions to generate hypotheses early on. While you are asking a question, مع أول سؤالين أنت بتكون you generated hypothesis. أنت بتكون خدت احتمالات وفرضيات لأنه العيان ده مشكلته شنو. Very early. The following questions ما حتكون من الليستة بتاعت الهيستوري بتاع الميديكال ستودنت. The following questions بتكون حسب الهايبوثيسيس اللي أنت عملت لها generation. وكل سؤال بيوريك أو أي سؤال إجابته بتوريك الأسئلة الجاية شنو. Because you are deducting. أنت بتعمل exclusion للpossibilities دي بأي سؤال until finally you smoothly land in a diagnosis. يبقى معناه شنو؟ The history is different from a patient to a patient. لو عيانين اتنين جو abdominal pain, the history through the hypothesis deductive model is different لأنه أي واحد أجوبته بتكون different. فالأجوبة بتاعت الأول ده لما يديني إجابتين حيكون عمل لي deduction لمجموعة من possibilities. I don't need to ask about that. I will ask other questions to rule out the other possibilities. والحاجة دي بتحصل at a subconscious level if you get used to doing it. I mean, you probably don't need to do it consciously. All what you need to do is to become aware that actually you need to pay attention to the answers of the patient and go through the probabilities that you generated in your mind. Question for you. What runs around the farm is small, feathered, lays eggs and barks? فزورة. Something runs around the farm, small, feathered, lays eggs and barks. Yes, a hen, a chicken. Yes, Sarah. طيب. A chicken. Now if you think of it, there is probably no single thing that will tick all the boxes here. But the point is, as a family physician, you don't get a textbook presentation. There is always something odd. So as a family physician, the message is this: you need to learn how to ignore the barking. You need to learn how to ignore the barking. Why? Because the whole context, the whole picture, gives you the probability, in the balance of probability, is most likely to be a hen. So this is what I meant. اخوانا هيجيك presentation زي ده، هيجيكم عيان الحاجات كلها not all of them would fit into a diagnosis, but you need to make a working, what we call working diagnosis, or what are you going to treat as, what are you going to manage as. Well, I'm going to manage this as appendicitis because yes, everything fits into appendicitis. It's not right, it's lumbar pain, not iliac fossa pain, but everything else fits into it. So this is the most likely. Now, if you are not comfortable with being able to ignore the barking, you will struggle in making a working, pragmatic, most likely diagnosis based on probabilities. تمام. أديكم مثال حي. 5th of January at 8 p.m. 13-month-old girl had a history of runny nose. Started 3 days ago and today started to have wet cough and some wheeze. She has no fever and never had similar symptoms before. What is the most likely diagnosis?
bronchiolitis.
Bronchiolitis, absolutely. لكن درسونا قالوا لنا في كلية الطب إنه bronchiolitis بيحصل في الناس اللي عمرهم أقل من سنة. كانوا بيقول لنا less than 12 months that is bronchiolitis, more than 12 months it might be bronchial asthma, probably bronchial asthma.
We have to ignore the barking.
Absolutely, we have to ignore the barking. Perfect. We have to ignore the barking. There will be something that doesn't fit. There might be something that doesn't fit. Like the skill of ignoring the barking can only be done if you are able to have a wide range of probabilities and be able to fit all the other informations into the most likely. We have it's runny nose for 3 days and then the cough is wet. That is very characteristics of bronchiolitis. The cough is not dry, it's like a wet type of cough, and there is some wheeze and there is some fever, and it's January, so the season of bronchiolitis. So you've got a lot of information that are enough in the balance of probability that will help you to ignore the 13-month in this occasion. طيب يبقى الخطوات بتاعت الhypothesis deductive model, it's like filtering the information. So you will ask questions. خليل الألم بتاعك ده هو من 200. طيب لو 3 أسابيع طوالي ولا بيمشي وبيجي؟ أيوة. طيب ها الحمام كيف؟ هل فيس؟ طيب كويس. أي إجابة للأسئلة دي بتعمل لك ruling out لبعض possibilities and you find yourself you're actually narrowing down into the working diagnosis. So you formulate the initial set of hypotheses, أو ممكن تسميها differential diagnosis, and then and this can be done quickly by an expert. So a very expert family physician, they might create the hypothesis after 2 questions. you might need four or five questions to generate the hypothesis, and then you obtain additional information to directed by the initial hypothesis. The following questions would be to deduct. يعني انت عاوز تطرح الهايبوثيسيس. في حمى قال ما في حمى، في 3 أو 4 hypotheses بيكونوا راحوا. Your next questions should be on the remaining hypothesis, and then you apply the rest of the information on the in order to try to confirm or rule out the hypothesis. So the diagram عشان يورينا إنه الزول بيجيك بالpresentation, you take some clinical data and early on you generate the hypothesis. يا اخوانا أنا الكلام I spend long time ليه؟ لأنه لحد سنوات طب إحنا بنكمل الهيستوري كله the same thing, and at the end of it we imagine إنه بيجينا وحي بالdiagnosis based on الهيستوري ده كله. One of the other problems as well إنه في ال clinical based problems اللي كانوا بيدونا لها سواء في الجامعة ولا في الامتحانات بيكون فيها فكرة بتاعت المساكات. والله يا أخي المعلومة دي لما تكون في إحنا بنعرف الدياغنوسيس كده، لما تكون المعلومة دي في بنعرف إنه الدياغنوسيس كده. So it created a culture of hunting in the diagnosis, hunting in a rigid structure of history taking rather than a structured way of reaching a diagnosis in an informed hypothesis deductive way of asking questions. The further data will be to rule out or validate the hypothesis before you reach the final diagnosis or management. يبقى انت بتبدأ you start from general to specific. You start by open questions. Tell me more about it. Okay, طيب ها كيف كانت؟ طيب اوكي طيب ها لما تمشي الحمام كده كلمني الحمام كيف. Start with open questions. It gives you more information than closed questions. It is a dynamic way, so the order of possibilities will move up and down according to the answers that you are getting when you take history. And the process goes through if, then, but, therefore, yes and no. So these are all the sometimes you would feel uncertain after a few minutes of talking to the patient. Then you will start saying, okay, I'm gonna answer this question. If they answered no, then I will go into that direction. If they answered yes, I will go into that direction. You would feel that, and it happens while you are asking the questions. طيب يبقى these are the two big methods that I want you to become aware of. The dual system method. الdual system method بالمناسبة ما بس في الdiagnosis، دي حاجة احنا بنعملها في حياتنا الشخصية في حياتنا العادية. System 1 and System 2. طيب there are other subconscious techniques that happens we probably helpful to become aware of. Compensatory control. What do we mean by compensatory control? When you are uncertain, you did ask all the questions لكن انت ما عارف الحاصل شنو. Then you would say I'm gonna ask a question or I'm going to do something, and based on this I will make that decision. بتذكر لما كنت house officer في السيرجري في الفاشر. كان we had a very experienced good surgeon there, and the on-call registrar كلنا عارفين acute appendicitis is easily diagnosed by a registrar، يعني ما بتحتاج حتى يضربوا للconsultant. لكن just this patient it just wasn't very clear. 2 registrars examined the child and they were like it wasn't fitting into acute well it could be عشان كده والله ندخل العملية ما ندخل العملية. So they rang the consultant. الconsultant قالوا له الهيستوري كل الحاصل still كانوا uncertain. فهو what the consultant said is قال لهم اعملوا التوتال، لو طلع اكتر من 8 خشوه، لو أقل من 8 خلوه. Now that is alright. But this is a compensatory mechanism. You try, because of the uncertainty inside your brain, you try to عاوز تفوض جهة خارجية, a blood test. ولا الregistrars اتصلوا بالconsultant, so they did actually delegate the decision making, or they asked the consultant to make that decision on their behalf. الconsultant بالنسبة له, he actually took the decision out of, or the responsibility of making the decisions, into something external, something outside their process of thinking, because it's very annoying لما تكون انت uncertain. فبتقوم فنعمل الوايد سيل كاونت, طلع اكتر من كده اقل من كده. The guidelines عندنا هنا قد يكون في UK اكتر حاجة بنستخدمها احنا as a compensatory control way here, using the guidelines, because we have guidelines for many things. So when things are uncertain, you will find guidelines somewhere to guide you. I'm not saying this is right or wrong, this is a phenomenon and this is the way it is. الحاجة اللي ما عاوزكم تعملوها إنكم تلجأوا للcompensatory control very early on, because you are not comfortable with uncertainty. You have to learn to become comfortable with uncertainty. Give yourself time to make decisions, to evaluate, to gather more information before taking this annoying responsibility of decision making to something external. لأنه كلنا عارفين إنه clinical appendicitis is a clinical acute appendicitis is a clinical diagnosis. Right, so messages to take home. زي ما قلنا clinical reasoning is dynamic, بمعنى إنه while you are doing it, you are revising the hypothesis that you generated. You are going back and forth. It is probabilistic. It's not black and white. And if you struggle to clinical reason during the consultation, recap and represent the problem. ديل نصيحتين أنا قاعد بقولهم برضو للناس. أحيانا أنت بتسأل طيب يا سيد خليل, طيب الألم ده كويس, طيب ماشي, أيوة, طيب تكلمت معه 10 دقايق لكن حاسي إنك أنت ما قادر تصل لحاجة. When you feel lost, أنا النصيحة اللي بنصحها للترينيز إنه في حاجتين: recap and represent. recap يعني ارجع الخص الكلام. اوكي, قول له طيب كويس كده, طيب انت قلت لي انك انت لك الم له 3 أسابيع وبيمشي وبيجي وكده وكده. لما ترجع تعمل summary بتحس انه الحاجات رجعت تاني تقعد بطريقة smooth in your brain. recap. represent يعني الكلام اللي قاله لك ده رجعوا له لكن بطريقة مختلفة. قول له يعني انت عاوز تقول انك انت كده لكن ما كده. this is how you represent something, and you will find yourself back on track. So don't worry about rushing the time. Always go back, recap or summarize and represent. ما عندنا كويز الليلة, لكن these are my references. You can screenshot them and وشكرا لكم. We can take any question, any comment. Let me stop sharing.
جزيلا دكتور مصطفى. لو في اي حد عنده سؤال او استفسار يا اخوانا, او في معلومه ما واضحه, او تفضل يعني.
في سؤال في chat. How can I apply hypothesis with patient-centered way? Is it by asking open-ended questions? Well, in fact, I think the clinical reasoning approach it actually supports patient-centered care more than doctor-centered care. الدكتور هو ما درس الهيستوري, الفورمات بتاعت الهيستوري اللي انت درستها والاكزامينيشن عشان يجي يديك المعلومات بنفس الطريقة والتسلسل اللي انت درسته. فأحيانا when you ask the question in that traditional way, it might sound very doctor-centered to the patient. يعني العيان يقول لك يا أخي أنا انا جيتك يعني ببطني، يعني فجأة كده تقول لي انت مثلا فجأة تقول لي انت شغال شنو مثلا، وانت انت شغال شنو، دي هي عندها أهمية من وجهة نظرك انت في الهيستوري، لكن the way it flew into the consultation is not as smooth as if you were using a hypothesis deductive method. عشان كده يعني مثلا انا اجي اقول لك والله يا اخي انا قاعد اقح، تقوم تقول له طيب والله يا اخي طبعا احيانا مرات من الاسباب اللي بتعمل القحة دي الحتة اللي انت شغال فيها، يعني لو فيها دخان ولا غبار ولا كده، فكده انت شغال شنو هسي يا سيد خليل؟ لاحظتوا الفرق ما بين انك انت تكون بتسأل فيه ايوه عندك القحة لامتين، فيها بلغم ما فيها بلغم، انت شغال شنو؟ س ف ف ف when you ask it and you ask the question and in your brain the hypotheses are being deducted، الأسئلة بتكون بتنساب بسلاسة. And that is how, and that is what patient-centered care approach is. Any question, any comment? دكتور عصام الدين عبد الباقي، مرحب بك ويتفضل.
السلام عليكم ورحمة الله تعالى وبركاته. جزاك الله خير. وللمرة الثانية أنا بستمتع جدا بالمحاضرة بتاعتك دكتور مصطفى، وسعيدين جدا بمشاركتك، وحرضت الناس الليلة إنه يجي يحضر إن شاء الله. رسلت لهم يعني، وأنا سعيد جدا أحضر. My question is, hypothetical deductive approach, does it contain both types of thinking, system 1 and system 2?
No, هو clinical reasoning is explained by you've got two big titles. The first title is the dual system way اللي هو system 1 و system 2 and the second is the hypothesis deductive method. dual system انه والله يا اخي انا اول ما افكر ده system 1 بيقول لي كده، بعد ذاك انا وظيفتي انه انا اعمل ريكروتمنت لسيستم 2 عشان يجي ويعمل questioning لسيستم 1 انه ليه قلت شنقلص، ليه قلت شنقلص، ما ممكن يكون كده، ما ممكن يكون كده. The hypothesis deductive method, you are generating the hypothesis consciously. يعني انت you don't just follow your gut instinct, you are generating them consciously and then you ask questions to validate them. لكن كلامك very relevant لأنه system 1 you can't disable system 1. يعني ما ممكن زول يقول أنا ما حافكر بسيستم 1. لا، هو system 1 ده هو أنت غصبا عنك بديك الامبريشن. أنت أول ما تشوف الزول كده طوالي بتجيك فكرة في ذهنك، الفكرة الأولى بتنط في ذهنك شئت أم أبيت. So يبقى حتى في hypothesis deductive method system 1 might play a role، لكن the idea is you consciously generate the hypothesis based on the questions and then you ask questions to validate them.
طيب سؤال، do you think إنه الدكتور should study thinking methodology with optional thinking or critical thinking؟ يعني should it be included in the curriculum, thinking methodology?
I think it should. Doctors make dangerous decisions every day, and I think if we are not aware of the flaws of our human nature in making decisions, it's a dangerous thing. Not just thinking methodology. I think thinking yes, and also human factors. احنا ده اللي هو دي حاجة احنا الليلة ما تكلمنا عنها خالص، لكن دي الحاجة when we talk about thinking, this is the way I think, human factors, the way everything around me affect me. فأنا I think إنه every doctor should study the reasoning, the way we as human think, the flaws in human judgment, and the human factors as well, how they affect our way of our decision making.
شكرا جزيلا، جزاك الله خير، ولا تحرمنا من طلتك يا دكتور.
شكرا يا دكتور عصام، وجزاك الله خير لكل العطاء الكبير اللي بتقدمه لطب الأسرة في السودان و and everywhere. أحمد خلف الله، تفضل يا أحمد. نعم يا دكتور أحمد خلف الله. You are muted. أحمد قد يكون عنده مشكلة مع الميكروفون. طيب نشوف لو في أسئلة في الشات لحد ما نسمع من أحمد. دكتور سلام كاشان.
طب دكتور بدي أسأل، لو بدنا نطور الكلينيكال ريزونينج في وضع ما في يعني مالي، يعني إذا احنا في بداية عمرنا بدنا نطور الكلينيكال ريزونينج بأسرع وقت ممكن، كيف الطريقة؟ نقرأ أكتر، وإذا كان ما كان عندنا مساحة لحتى نختلط بناس مثلا فاميلي دكتورز مثلا عمرهم 60 سنة عندهم خبرة واسعة، الأمر هذا لو كان مش متاح فبيكون الموضوع صعب، فهاو we can compensate هذا الإشي.
That's a very good question. I think, by the way, being very, very experienced doesn't mean automatically you will become a clinically reasonable clinician. I think one of the important things to think about is the humbleness, becoming humble and accepting that, well, I am human, and to avoid being overconfident. One of the problems with there is a very interesting study that was done in the United States a few years ago, and they identified what is known as the expert bias. So when people become more and more experienced, they become overconfident in their decision making, so they don't actually question themselves all the time. Having said that, experienced family doctors or experienced doctors in general, they tend to use the hypothesis deductive method more than junior doctors, but that doesn't mean they always do. There is a tendency, but that doesn't mean they always. So just I would be careful. Just being close to somebody who is very experienced doesn't necessarily mean I will be using the clinical reasoning. I think the best way is to first to become aware of it. We have to read about it, yes, but also reevaluate your own thinking. Now I'm trying to avoid saying try to apply it, because it's not always that straightforward. I read about clinical reasoning, I'm going to do it tomorrow. The best way to do it is to reflect on your own performance retrospectively. After every clinic, try to say, well, my last patient, for example, or my first patient, how did I reach that diagnosis? What was going on in my mind? So this is what is called metacognition, thinking about thinking, and I think that is the best way. And not everywhere in the world reflection is a part and parcel of family medicine training. Reflection is a very, very essential way of learning clinical reasoning, because in reflection you are looking back into your thinking and questioning the way you thought about the way you reached the diagnosis, and that would help you to develop more. So yes, reading about it, teaching it, being with people who are experts, but being cautious with that, but more importantly reflecting on your own decision making.
Thank you.
Yes, I think let's have a look if there are any questions on the chat. if I recap with my patient, do you think the patient feels I am understanding and going thoroughly with him? Otherwise, I get lost. Yeah, I think one of the benefits of recapping is sending the message to the patient that I was listening. Imagine انت لما تكون بتتكلم مع زول، اي زول حكيت له مشكلة، يقوم قبل ما يديك نصيحة يقول لك ايوه يعني انت قلت لي انك انت اصلا عملت كده وحصل لك كده وبعد ذاك مشيت وكده. اوكي. How do you feel? You feel pleased that they were listening to you. So the benefit of the recap is that actually patient would feel you'd listen. So it's not just actually getting you back on track, it's actually getting the patient on your side as well. I think there were some more hands raised, I don't know. Hands came down. We have 3 minutes before we finish an hour. If there's any more comments, any questions. Yes, Ahmed Khalafallah.
هذا شكله عنده مشكلة تقنية. في
Yes.
سؤال من دكتور مياد ده بتقول when I cannot reach the diagnosis from hypothesis, what to do?
Sorry, what was the question? Oh, when I cannot reach the diagnosis from hypothesis, what to do? The same thing. Follow this. Recap, summarize, and go back again. So recap and represent. أرجع تاني أعمل recap. أرجع تاني represent. And we have to accept sometimes we just don't know what's wrong with the patient. Uncertainty is part of this. One of the things that I teach our trainees is how to become comfortable with uncertainty. We had a whole afternoon the week before last week on managing uncertainty in primary care, and the important thing with uncertainty is to accept it. It's okay to say to the patient والله يا أخي صراحة أنا ما متأكد والله يا أخي مشكلتك شنو، لكن كده خليني أشوف زول تاني، خليني أتناقش مع زول تاني، خلينا نعمل كده، خلينا نعمل كده. By the way, patient will trust you when you are honest, when you honestly say I don't know. So it sometimes just happens. لكن the answer to your question is if you are lost with the hypothesis, just go back, recap, represent, and try again. But more importantly, sometimes you just don't know what's wrong with the patient, and you have to either get advice from someone else or reflect that to the patient and be honest with them. Yes, recap is summarizing. Okay. طيب يا دكتور سامح، شكله يعني ما أظن في more comments ولا أسئلة.
طيب إن شاء الله نشكر الدكتور مصطفى. تفضل دكتور عصام.
شكرا جزيلا يا دكتور مصطفى، أنا مستمتع جدا جدا يا أخي. بالمناسبة أنا عشت طفولتي في الفاشر، يعني شايفك ذكرت الفاشر، مستشفى فاشر ده عالجت فيه سنة 1963.
يا سلام يا سلام.
دي ذكريات جميلة من هناك. يعني أصلا أول ما وعيت عرفت الدنيا عرفتها في الفاشر هنا، يعني أبو زكريا.
It's a place I enjoyed working in.
يا سلام يا سلام. كان المفروض نمشي ننزل فيها منهج طب الأسرة في كليتين، كلية الفاشر الأندر جرادويت